I don't want to interrupt Jackie, but I know you're fine, but I just want to make sure we have lots of time because I feel like there might be a lot of things that people want to ask questions about or discuss because even though we are through the emergency phase of the COVID-19 pandemic, I feel like this brings us right back to it and we'll have lots of questions and our presenter will have lots to say. Thank you everyone for coming to our Book Sandwiched In program on this beautiful spring day. I'm Dina Viviani, the programming manager, and I just want to start with a couple housekeeping tips. First, for anyone using a hearing aid, we do have our induction loop system, so you can turn it on at any time. At the end of the program, when we have time for Q&A or any group discussion, please wait for this microphone so everyone can hear and participate. If there's a need to evacuate the building, the door on my right, your left is our closest exit. And I want to thank the Friends for sponsoring this program and most of the programs we do. Please pick up one of our May program brochures. We've got them over on the table by the door. We have a lot going on this month, but we've got more craft programs. We've got a cool program for all of us book lovers called the Inside Scoop on book cover art. That is presented by a cover designer, Stephen Breda, art director for HarperCollins Publishers, so that's pretty cool. We've got some other health programs, we've got some other history programs, so please check one of those out. And then stay tuned for June, we have our next Big Friends book sale, which will be in this room. So we're still taking donations, and that of course helps us fund our next programs. All right, and today we are really excited to have Tim Czapranski here. Tim is the Monroe County EMS Administrator. He's been engaged in many facets of the EMS service, public safety, and medical communities at all levels. Some examples include coordinating the vaccinations of county first responders, including managing the county point of dispensing, field response to county fire special operations and hazmat events, and coordinating EMS response to civil unrest, including embedding EMS with law enforcement tactical teams. And his resume goes on. The only other thing I want to make sure I point out is that the Rochester Business Journal awarded him the Hero Award for his work during the COVID-19 pandemic. So we're really happy to have him here to talk about writing the language. Thank you.
Thank you. Everyone can hear me okay? All right, well, thanks for coming out, and I appreciate the invitation to talk about this book. This is a book that I probably went down and read as early on as I did, unless I was invited to read it and to review it. It's a pretty raw book. I think those that you read it pretty much get that feeling that the author was pretty honest and open, not only about his personal life, but about what he was seeing in the streets in New York City. He and his colleagues were seeing in New York streets. First thing I noted about the book was Riding the Lightning, right? That's a pretty intense title. So in EMS, depending on where you are in the country, using electricity to reassign or realign the heart, whether you're defibrillating somebody in VTAC or VFib, he refers to it as riding the lightning when you shock somebody to try to reorganize the heart's electrical rhythm. Other places in the country it's called Thor's hammer because it's a thump, right? Other people call it Edison's electric. But riding the lightning actually is a phrase that came from a Stephen King book called Stand. And in reference when Stephen King used it, he used it as the electric chair to kill somebody, using electricity to kill somebody. So it's a little unique that we use riding the lightning to use electricity to save somebody when its initial thought was that it was used to kill somebody. For me as a paramedic, going into the pandemic, going into uncertainty and unusual circumstances was nothing new. We do it all the time, whether we respond to riots or whether we respond to disasters or whatever. Every call we go on is different. We don't know what we get until we get there. So when we entered the pandemic, it was like, yeah, this is kind of cool because we've never been in a pandemic before. And it was kind of cool for like 4 or 5 weeks, and then it started to get old because everyone was getting exhausted. But how many people watched the eclipse? So for us in Rochester, it was kind of like watching that shadow move towards us from across the fields because it hit New York City and it hit New Jersey, it hit Massachusetts and Rhode Island, it hit Connecticut. And we were watching what happened. We tried to learn what we could, what was published from the Spanish flu 100 years ago, and there wasn't much there that would help us. So we were watching and talking to our colleagues downstate and across the country about what were they experiencing and how do we prepare for it. So we had, in Monroe County, a little bit more prep time. We got to see it move towards us like that shadow on the eclipse. We could see it coming. We could see it march up the thruway, we could see it hit Albany, we could see it hit Syracuse, and then obviously Rochester and Buffalo. So we had time to prep, we had time to work on PPE, we had time to work on the things that they didn't work on. But if you remember when the pandemic hit, he talked about in his book, we as EMS providers were told, you don't need masks, you don't need them. It's not airborne, it's not person to person. And so we were sending our EMS providers out there without that PPE or without that protection. Here in Monroe County, our EMS agencies do what's called standard PPE. So when we go into a patient, we typically mask up and glove up when we see a patient. And that's kind of standard. And we kept that standard in place, which I think helped us a lot. What we didn't do was mask up and gown up. And especially when we're doing endotracheal intubations or we're opening somebody's and putting a tube down the trachea, we didn't necessarily take the PPE that we should have for that. Because again, we were being told it was completely unnecessary. As you know, those that read the book, how many read the book? Oh, great. It's organized, chapter organization is by month. So it was like March 2020, then April 2020, then May 2020. So it talks about EMS as a brotherhood, or brotherhood and sisterhood is what they mean. And that's true. It's kind of like law enforcement and kind of like the fire service. We all have shared experiences around emergencies that are often tragic. EMS and law enforcement are a little different than the fire service. The fire service goes out, goes to a fire as a group, comes back as a group, stays at the firehouse as a group, bunks as a group, eat meals as a group. EMS and law enforcement go get their briefing at the beginning of the shift, and then they disperse. And EMS does what's called street corner posting. And what street corner posting is, rather than have a station, we have to follow the people. So the people move. Unlike the fire department that is structure-based, how many structures there are and what's at risk, EMS follows people, and so does law enforcement. And people move from work to residential areas. So we do street corner posting. Surprisingly, EMS 911 calls are predictable. And I know that sounds unusual because no one plans to get up in the morning and call 911, right? I'm going to call 911 at 1 o'clock, or I'm going to get in a traffic accident on the way home. But it is predictable when we go back and look at it. And so we look at EMS at the high acuity calls by hours of the day of the week for 168 hours of the week. And then we plan where we put those ambulances based on the historic call volume for those high acuity priority 1 calls. And we adjust it by season of the year because winter's different than the summer. So if I have 5 ambulances, where I put those 5 ambulances today at 12:10 is different than where I'm going to put those 5 ambulances Saturday night at 11 o'clock at night. So we have to have that mobility to be able to move. And so there aren't stations all over the place to accommodate that. So a crew parks at a street corner, and you'll see them parked at a street corner. So they don't have that same level of brotherhood like the fire service does. Same thing with law enforcement. They go out and they don't get back until the end of their shift, or most likely with EMS an hour or two after the end of the shift because they had a late call. So that's kind of the challenge. What it does do is endear you to your partner because you're sitting in an ambulance for 14 or 16 hours and working together. And you typically work with the same partner for months, if not years. And so that relationship develops over time with that. In the preface, he talks about everything changes. Everything did change for EMS, and that was true for us here as well. Now, in Monroe County, people call 911 150,000 times a year for EMS, about 80,000 times a year for fire, and hundreds of thousands of times a year for law enforcement. But when everything changed for us, and it was a constant change, the protocols were changing, the PPE changing, everything was changing, sometimes twice, 3 times in a single day. And it was hard for our EMS providers to go up to. It was hard for us to communicate it out to them. So we had in Monroe County daily conference calls with our EMS chiefs, and not just EMS, we included the fire chiefs, the law enforcement, probation, jail deputies. Eventually, other counties started calling into our daily calls because they weren't getting information that they needed. And frankly, our surrounding counties are pretty rural. They don't have the infrastructure to be able to do that. So we had our medical director on, and we would go down and give reports from each of the individual public safety disciplines that was still responding into the field. We stood up our emergency operations center, and we were there for day in, day out for a long period of time. And our public health officials were really much like us, inundated with a lot of stuff. So our law enforcement and our fire colleagues, which typically respond to high acuity calls with us, no longer were responding to high acuity calls. And he mentions that in the book. Fire departments that went to low acuity calls stopped going to low acuity calls. Law enforcement stopped going. It was just EMS. We couldn't stop going, so it was us alone out there. Now, he has a little bit of issue with it. I don't, because it was clinically appropriate. So, and here's why. You have 4 firefighters on a fire truck and 2 people on an ambulance, 2 medics on an ambulance. That's 6 people going to take care of 1 person, right? So each one has 2 pairs of gloves on. So you've got 12 pairs of gloves used. Each one has an N95. That's 6 N95s. Pull this away, you got 2 N95s, 4 pairs of gloves, right? And the clinical outcome for the patient is probably not going to be any different if they don't go. And you're exposing 4 other people to COVID that don't need to take it back to the firehouse and expose their colleagues and their families. So clinically, we made a decision it was appropriate for fire to pull back and for law enforcement to pull back on these COVID-related type calls. And I think it worked well. I think we were able to control the COVID in most of the communities that we service. EMS is interesting in New York City. You know, he talks about the diversity of EMS, and we'll get into that in a little bit. But the strain on EMS was pretty tremendous. At a time when they're having double or almost triple their call volume, they've got 25% of their workforce out sick. So you can imagine the strain. So it goes from call to call to call, and he talks about that. And we have the same thing happen here. The minute you go back in service in the hospital and push the button so that you're back in service, you're on another call. And that is constant. So there's no downtime. People who want to use the bathroom have to use it in the hospital. If you want to try to grab a bite to eat, good luck. A lot of people didn't get much to eat during those days of COVID on the EMS side, and it was frustrating. He talks about first-time calls. In this case, he references a delivery of a baby, and I think every paramedic who has delivered a baby, and almost all of us have done it a lot, you remember that first one because you practice it with mannequins when you're in class, but when it actually happens, you learn a whole lot on that when that mom delivers that baby, because those babies are really slippery, and it's a mess. And it's really unique. My first delivery was in Louisiana, and I was in Vacherie, Louisiana, and we had a patient who had 5 kids, and this was her 6th pregnancy. And she was hilarious because I get there, and she said, "You look scared." I said, "No, we'll get through this." So we did. She had the baby. She said, "I'm having the baby." I said, "Well, we're only 40 minutes from the hospital." "No, I'm having the baby." Okay, so pull over. She had the baby, and as I'm finishing up, and then she starts nursing the baby, so I want to put a sheet over her. She said, "Are you embarrassed?" I said, "Well," she goes, "You look awful white." And she said, "The advantage of being African American is you can't see us blush." She ended up naming the boy after me, so that was kind of cool. But she got me through that first one, and I'm glad it was her that did it. He talks about group home and the band of misfits, and he talks about he's attracted to other people who have past traumas in their life, and we know that he had a lot of trauma in his life. You know, at 14, his dad left, right, with his older sister's classmate who was a heroin addict. At 16, his brother dies, and then his mom never really focuses on him because his older brother's so troubled that she spends all her energy trying to work through him and keep him out of trouble, and it doesn't really work. He was an EMT, so you know he was a bagel shop guy, and when the EMT crews would come in to get bagels, he'd ask them about what type of calls they wanted. And so he got interested in EMS that way. Everyone gets into EMS in a different way. Typically, law enforcement and fire, you have a relative or a father or a mother that's involved in the service, and you get into the service that way. EMS is young; it really started in the 1960s, so it doesn't have that history. So people come to EMS from different angles. The way I got into EMS was I was a deep sea commercial diver in the oil fields. So that's a hard hat diver, and we would dive and we would do what's called CERTIO2. It's not scuba diving. You wear a big hard hat and have an umbilical, and you dive alone. And when you get up, instead of doing water stops to decompress like a scuba diver does, you come right up to the surface, get everything stripped off, you hose down, you climb into a chamber, a decompression chamber, you blow down to 40 feet, you put on an oxygen mask. It's called CERTIO2. And that way you get the maximum bottom time and work time out of your divers by keeping them what's called a no diver. So What we realized is when divers came up missing fingers or missing hands or broken bones, whatever, they had to decompress. So we could call an EMS helicopter, come offshore, but the paramedics and EMTs, they couldn't blow down into hyperbarics because they didn't know about hyperbarics. Only divers did. And so we thought, how do we fix this? Because the diver's down there alone, bleeding, and trying to fix it himself. So we decided we're going to train EMTs and paramedics in hyperbarics, and we found out that it's a lot easier to train divers in EMS than it is to train EMS people in hyperbarics. So a bunch of us, we worked for a company called Seacom, which is a subsidiary of CBI. So we worked in the Gulf of Mexico and sometimes the North Sea. So we all went to an EMT class in Lafayette, Louisiana, to become trained so that we could blow down with our fellow divers when they were hurt and take care of their injuries or their illnesses. And that's how I got into EMS. When I got into diving, because all my colleagues were dying and my wife said, you got to choose your job or me, and I chose her. So I was already an EMT and I hired on with Katie an ambulance to start writing on ambulances. And it's basic EMT to do. I wanted to be an intermediate, became an intermediate. That didn't do so. I went to University of Mississippi Medical Center for my paramedic. And then we decided we didn't need to live in Louisiana. We could live anywhere we wanted to because I wasn't tied to diving anymore. So we moved up here. But everyone has their own journey into EMS. He talks about holidays, and he talks about he wants to work holidays because he wants to be around people. He doesn't want to face the difficult choices of what he does on a holiday because he lives alone. He has nobody in his life, really. And so he chooses to, and I think the right choice, to be around people during the holidays rather than alone. Typically, holidays are a difficult time to get EMS personnel to work. And usually the ones that volunteer to work usually are from somewhere else, have no family, maybe are students here at the U of R or somewhere else that are working at med school, and they're not going home for the holidays anyway, so they decide to work. He talks about the people we treat, and he talks kind of at length about how they mimic the EMS group as a whole. So I just wanted to read a couple passages from him, but first this one. And he talks about Chris and Anthony, who are two friends of his. One is an epileptic who doesn't take his medications. Anthony has hypertension and doesn't take care of it because he doesn't have health insurance. I treat patients like Chris and Anthony all the time, people who will most likely die of preventable diseases because they don't have insurance and they can't afford their meds or simply don't take them. Neglect and poor mental health don't make for long lives. Survival rates in my family weren't so high either. My older cousins, the ones who used to come up for Thanksgiving, all died young. Aunt Marison's daughter, Donna, died of AIDS when I was 12. Mimi, her other daughter, died of HIV-associated pneumonia. Marianne's son, Tuffy, got into a fight with a local guy when he was in his 20s. I still don't know why. The guy stabbed him to death. Marianne herself lost a leg to diabetes and then died in the 2000s, not long after Mimi. Even my nephew, little Eddie, Yvonne's son, a gentle soul, made it only to 29. He got into bodybuilding and took steroids. I warned him not to. The steroids destroyed his immune system. In 2014, he developed pneumonia. They found him dead in his bed. And so, from that personal experience, when you have that kind of tragedy in your life, I think someone's naturally called to try to help people. And I think that's one of the reasons that he enjoyed EMS so much. He talks about he went to the fire academy and lasted a couple days, and then he went back to EMS because he didn't like the discipline there. There is clearly a disproportionate number of 911 calls, and I think that's true of every major metropolitan community, and for the poor people in our community. So the majority of calls that go to the inner city of Rochester, for instance, because frankly the poor in many cases have complicated medical conditions, but oftentimes they're doing their best to just put food on the table, and they don't really know how to access the medical system. No one ever taught them that in high school in class, and I don't think they do. You know, I know the system from inside out, so I can help my family members navigate the system. I've got a sister that's a nurse practitioner at Strong. My daughter's a nurse, so we kind of know how to work the system. But clearly there's a disproportionate number of poor and minority communities that call 911 for their primary care. And we often find when we ask, who's your PMD, who's your personal medical physician, they don't have one. They get their primary care by calling 911 and going to the emergency department, which is not really good because the follow-up from an emergency is not that good. So we work in this community to try to create navigational courses and healthcare coaches and stuff like that to help these people navigate the healthcare system to their benefit. So rather than taking the most expensive form of transportation to the most expensive form of treatment with no follow-up after the fact, and try to get them into the system so that they're followed on a regular basis. And that will improve both their quality of life, it will lower the expense for the healthcare system, but more importantly, it'll lengthen their life as well. So we continue to work at that, but he points out that the same thing is true in New York City. About diversity. So throughout the book, he kind of dribbles or drips diversity in the EMS world. And he talks about how we mimic the society we serve, more so than maybe some of the other disciplines. And there are reasons EMS does that. I'm going to read to you just real quick. This is from page 94. We talk about the Phoenix Society, an FDNY association for Asians and Asian Americans. The society who's represented the department in the parade, and I am a member. We're a pretty small group. People of Asian descent make up only 5% of the EMS workforce and 2% of the fire department as a whole. In a city that's about 14% Asian. The fire department is the least diversity uniformed personnel in New York. If you leave out EMS, it's 99% male and 77% white. The EMS division, by contrast, is 72% male and only 41% white. So clearly a difference in the uniform of EMS. I mean, when you factor, you have only 41% of them as white. That means, the other 59% are minorities. And so that's when he talks about we look like the community we serve. And I think for the most part, that's pretty true across the country. Regulars, he talks about regulars and what I refer to as frequent flyers. And every community has regulars and frequent flyers. And these are people who call 911 on a regular basis. And they call for different reasons. Sometimes they're cold, sometimes they're wet, sometimes they're hungry, sometimes they haven't taken their medications, sometimes the blood sugar's low. But most of all, they're homeless, they're alcoholics, they're drug addicts. They've got lots of things going on in their lives that make it difficult for them to take their medications or even get their medications. You can imagine somebody who's hearing voices all the time and seeing things has difficulty going to the store and get medications or remember to take their medications. So inevitably then off their medications and then they end up in a crisis. And they call 911. The one thing I teach every paramedic is that when you come into EMS, every patient you see, every person you see deserves your respect. I don't care what the circumstances of their life are. I don't care what it smells like, I don't care where they live, I don't care if they're homeless, they deserve your respect. And if you treat them with respect, you will find them very easy to work with and very easy to help them. If you go in there with an attitude, you're going to create problems. And no one needs to do that. Every patient deserves your respect, period, right from the get-go. So he talks about several different ones. And I'm going to read you a little bit about classic tile. Do you guys remember that one? You read it? Then there was Classic Tile. Classic Tile hung out in Bensonhurst, not far from where Joe lived. He was short, Latino, and ill-tempered. He was an alcoholic. Classic Tile wore a gray sweatshirt from a nearby tile store with the same name. He said he once worked. Classic Tile also claimed that he worked on the construction of the Twin Towers. It was very possible he did, but he did not work on anything anymore. Some days Classic Tile was borderline comatose. Some days he was mad. Often we get calls from the MDA because he was urinating, he uses a different word in here, on the wall of the subway station. He would take half-assed swings at the paramedics and EMTs who picked him up. He once flanked down Kenny's ambulance, then cursed him blindly when he stopped. Kenny was one of the most good-natured EMTs you ever met. He did not like Classic Tile. Classic Tile had a raspy voice and 3 sentences in his repertoire. He'd flex his arm, spat out a line, and slap his bicep. I worked for Classic Tile for 20 years, slap, slap. I worked on the Trade Center, slap. I'm not a criminal, slap, slap. And that was all Classic Tile would tell you. He wouldn't tell you about his history, he wouldn't tell you about what was going on. And that's often the case with many of these behavioral health patients. And so we try to figure out how to help. But one of the things we did was we learned that taking them, especially during COVID, taking them to the chaos of the ED was not necessarily in their best interest. The EDs were overwhelmed. EMS crews were sometimes in line for 3 hours to drop off their patient. So that means 3 hours they're not in service serving their community. And so we worked with the behavioral health community to create what's called the BHAC. And that's the Behavioral Health at St. Mary's campus downtown in the city of Rochester. And it's like an urgent care for behavioral health needs. So obviously if someone sliced a wrist or did something like that, we would take them to the hospital because they need a surgeon. But otherwise we would take them to the BHAC because they would be seen right away. And then there was follow-up care for them. So it was much more appropriate setting that they could get the care that they need. And that continues on today. We continue to transport to non-traditional settings to try to get these patients the care that they need. In page 131, he talks about essential service. So for those of you who don't know, essential service is a definition that means the government is responsible for providing or making certain services provided to the community. So law enforcement is an essential service. Fire departments are an essential service. EMS is not. So it was in Governor Hochul's budget to create a law that created essential service for EMS, and it was taken out. So we're going to continue to work on trying to create EMS as an essential service. Because I don't think anyone will argue when the fire departments aren't going on the calls and the police aren't going on the calls and it's EMS alone, it's pretty much an essential service. When you're having a heart attack, it's an essential service. When you're shot, it's an essential service. So he talks about a motor vehicle accident. So you get fire, police, and EMS in the non-COVID time at a motor vehicle accident. The one with the most training and is going to take care of your bleeding and broken bones is the least paid one in the group. And so essential service looks to try to bring equality to those. I'm not saying firefighters get paid too much or law enforcement. Absolutely not the case. They get paid what they get paid for a very good reason. They create risk and they are in risky environments, but so is EMS. So I think we need to get it. He talks about a lot about the death, and I think you guys read a cardiac arrest protocols that changed that said, you know, if they're in asystole flatline, you're working for 20 minutes, give epinephrine and bicarb, call it a day, clean up and go home. And that continues. So after a period of about 2 or 3 weeks into it, all of a sudden the members start getting COVID. And so that the workforce reduction. So the call volume is still there, and now you have reduced workforces. He talks about 25% of the workforce out. And all the cardiac arrests, it's interesting. So one of the protocol changes, and it happened throughout the country, was when someone calls 911, and if they're alone, and it's a COVID type call, we would tell them leave the door unlocked or leave it open. We don't tell people to do that with other calls. But we did that, and here's why. All over the news, we remember the EDs. You know, no one could visit their relatives or loved ones in the hospital. It was full of COVID. It was bad. It was chaos. It was bad. They weren't getting care. Well, fortunately, our community, even though that all existed, they were able to triage the sickest patients first and get them in and get them treated, which meant that those with minor injuries or minor illnesses were waiting a long time. But one of the things it did was if you felt like you were coming down with a common cold, you sort of weighed, well, my doctor's not seeing patients. I don't want to go to the hospital because I'll get COVID. This may not be COVID, so I'm going to stick it out at home. And then they stick it out at home for a day or 2 or 3. The problem we found with COVID, even in the ICU, was that you could crash in 3 minutes. I mean, we have one paramedic who's also a critical care physician in the ICU. He's also an anesthesiologist, was a previous paramedic. But he talked about he carried RSI, rapid sequence intubation medications, in his pocket because he would walk by a guy who was eating in the ICU. A minute later, the alarm's going off, and he's going, and his pulse oximetry is at 50. And that's the measure of oxygen saturation in the blood. So he'd have to intubate him to breathe for him to get him back. And so what we found with these patients, they waited and waited and waited, and then they called 911, and they erupt. They stopped breathing, and they went into cardiac arrest. They waited too long. They waited until they were in a real fix, trying to suck air into their lungs, and they couldn't do it anymore, and their last act was to call 911. So that's why we found so many people in cardiac arrest. In the beginning, they would collapse, and we couldn't get in the door. So we'd have to call the fire service for forced entry. So then we changed the protocol to say, let's leave your door open, or let's leave it unlocked so that the medics can come in. We don't have that delay of getting a forced entry. And they saw that a lot in New York City. So again, Another protocol change, shutting down bike. This one was at ECD, or Emergency Communications Department protocol. End of the first week of April, more than 800 deaths in a single day. 1 week after, one died on an average of every 2 minutes. So I've been talking for 30 minutes, that would be 15 dead. You know, that's what they were looking at down there. And that is a difficult situation. I'm going to read, because probably this stood out most to me, of what he did. And it's on page 151. So this is a Sunday, and when you pronounce 4 people dead before lunch, the well of empathy, of perspective, it starts to run dry. That Sunday became a blur. House, apartment, nursing home, Bay Bridge, Bath Beach, Sunset Park, grandma, uncle, mother, son. I responded to 14 calls in 16 hours. I traced a miserable zigzag across Brooklyn. Almost every patient presented with COVID symptoms. Every patient died. I've had bad shifts in my time. I think every paramedic has. I've never had anything like that, nor would I want to. Now, at the end of 16 hours, emotionally he's exhausted, physically he's exhausted, mentally he's exhausted. And he goes home and there's no family, there's nothing there, he's alone. That's gotta be a tough one. But then when he tries to sleep, he can't. You know, physically, yes, I'm tired. Emotionally, yes, I'm tired. But mentally, my brain's racing. And I know that feeling because it happens to us on very difficult call days. You can't sleep. And then finally you succumb at 2 or 3 in the morning and you wake up after a couple hours and then you're back at it again, but now you're down a notch or 2 from where you were. So he goes on to say that I opened the back door of the truck and sat with my legs dangling. I stared at my hands. I was shattered. It's hubris to think that we can always save people, that we can give them life. It's egotistical, I recognize that. But it's what sustains you, the possibility that you can save someone. And we weren't saving anyone. That, to me, the whole book touched me more emotionally than any other part because I know what that feels like. So he gets to the point, I think, where he almost gets into burnout. So then April comes and things start to improve. The call volume for COVID patients goes down. The number of deaths goes down. The number of hospitalizations go down. FEMA sends 250 ambulances to help them. And 250 ambulances running 24 hours a day, 7 days a week is a good thing. But sending 250 ambulances has its own infrastructure problems. They don't tie into the New York City CAD system or computer-aided dispatch system. They don't have radios that operate on the frequencies of the towers that New York City has. They don't have mobile data terminals in their ambulances to tell dispatchers when they're on the scene, when they're en route, what hospital they're going to. And they don't have their own dispatch centers. So all that needs to be set up. Normally, and a good friend of mine was responsible for doing that in New York City. He left here and went down to New York City to set up that dispatch center and get that whole thing running. And normally, you know, he kind of went there with trepidation because in government, you have to get so many levels of approval. If I sign a contract with a CAD company to get a computer-aided dispatch center for $300,000, it's got to go through the law department, it's got to go through purchasing, it's got to go through this, it's got to go through that. That's a multi-year process. That didn't happen here. Because of the state of emergency, he was given the authority to sign those contracts, he was given the authority to purchase those things, and to make it, quote, make it happen. New York State Department of Health, Bureau of EMS and Trauma, really outdid themselves when they were able to do that. And they did it on the fly quickly and got those 250 ambulances in service. So that was fortunate. You hear them talk about that they did the low acuity calls. They did the homeless calls, they did the behavioral health calls because the paramedics in New York City still wanted to do the critical calls. But it offloaded them from those other calls, so it helped them, I think, substantially. And then they started to lose their own. And I think he talks about that, whether it's a loss of Joe from a posterior MI, or it's a loss by suicide, or it's a loss by COVID. It's one thing when you lose someone, I think we humans are made resilient enough to take a gut punch when we lose a loved one. It's another thing when you've been in this environment day in and day out, and then you take a gut punch like that. It's like being in the ring with Mike Tyson for 38 rounds when he was in his prime. That first punch in the first round you can absorb, but the way you absorb it after 38 rounds is completely different, both mentally and physically. And so it impacts you a little bit more than it might normally otherwise do. It talks about PPE and N95 masks. And N95 masks are the gold standard in the EMS world and the medical world for that matter. 0.03 microns is what they filter to, so the virus doesn't penetrate it. It's actually called a respirator. You get fit tested for these things. So they put them on and then they put over you and give this very sour or sweet powder buffed in there, and if you can smell it or taste it, then it's not fit properly, so you get fit tested for your N95 mask, which is good. You know, I take a 3M medium N95 mask. That's my fit test. Well, that's 80% of the medical population takes that. So what do you think happened to the 3M N95 medium masks? They were gone, like that. No one stockpiled. I mean, the Department of Health did, but hospitals, EMS agencies, the way the economy was running, they were doing just in time stockpiling. So if they had a week's worth, that was good, because if a snowstorm came and they couldn't take deliveries, they had enough to get through the week. But they didn't stockpile any longer because there's a cost associated with stockpiling and storing those goods. So it became just-in-time inventory, not just for us, but for hospitals. When a snowstorm hit Buffalo, the main neonate fluid that came out of Buffalo was manufactured in Buffalo, came from Buffalo to the University of Rochester's neonate center. And when the snowstorm hit and they couldn't get it out, the hospital had a couple days supply. So we had to work with the Army National Guard to get that supply rolling again. So the fact that everyone had low stockpiles for just-in-time inventory meant that there was an immediate demand across the country and across the world for N95s. Now, by the time we got to it, it was pretty much exhausted. So we relied on a stockpile that the public health department had in our fleet center to get us through. But the unique thing was that wasn't enough. We were out of gallons. We were running out of gloves. People were double gloving because you take care of a patient and then you go touch door handles. You're spreading the virus, so you peel them off and touch the door handles and do those kinds of things. And so we had some kind of unique individuals in our EMS community, had broad interests. One paramedic, she rescues animals on the side. So she knows all the veterinary clinics. She knows all the vets. She knows all the veterinary hospitals because that's her world outside of EMS. So she would call on them and say, are you guys doing elective surgeries? No. Are you guys out? No. We need PPE. Do you have gowns and gloves and masks? Yes, you can have it. Here you go. And so we piecemeal together in our community enough to suffice. And so it was difficult, it was a challenge, but the community rose to support us in our needs, and that was great to see. Later on that month, more normal call volumes returned. So for us, after that peak wave of COVID, when the call volume returned to normal, it actually dropped below what we would normally see. People were still in their houses. People were still not going out. People were still wearing masks. Schools were still closed. Stores were still closed, except grocery stores or essential services. And everyone stayed at home. We weren't responding to schools for kids that were injured or sick. We weren't responding to MBAs. We weren't responding to gun shop wounds at nightclubs because everything had tapered down. Society was hunkered down. And that was good and bad. I think one of the things in my experiences in May of, I think it was 1982, May of 1982. May 18th, 1982, I was in Portland, Oregon. The week before, I had gone across the border to Washington with a friend of mine, and I climbed up Mount St. Helens. Exactly a week later, it blew. Now, I will tell you, I was 20 years old, and finally a helicopter came over us and ordered us up the mountain where we could be arrested. So we got down and left, but you're kind of bulletproof, and the thing was spewing ash, so I was into photography, and so there were a lot of people down the mountain, but we had gotten up the mountain to get a lot of photography. And so on the 17th, there was all that pressure, right? On the 18th at 8:32 in the morning, they blew. It's a good thing it was a Sunday and it was in the morning because hundreds of people would have been there in the afternoon taking pictures. So that was kind of fortunate. I look at COVID as kind of like a pressure dome building. got all these people who have lost loved ones, who have lost jobs, who can't pay their rent, can't pay their mortgage, and the pressure's building. How many people in here have been touched personally by COVID? Yeah. And so you've got this pressure building. And so EMS is normal, everyone's beginning to relax, and then George Floyd is killed. And everything goes in a completely different direction. All of a sudden, May 17th becomes May 18th, and it blows up. And it doesn't just blow up in Minnesota. It's in New York City. It's in Rochester. You guys saw it. It was flipped over, cop cars burned out, riots. So that was the new EMS norm. So in addition to wearing gowns, 2 pair of gloves, and an N95 mask, we're now wearing ballistic helmets and bulletproof vests. And again, this time it's not us on the front lines, this time it's law enforcement, but we're there supporting them. And EMS rides a thin line, because we're there, because the cops are getting injured, we're treating them, taking them to the hospital, but the protesters are getting injured, so we're treating them, taking them to the hospital, because we don't draw a line. We see a patient, and we take care of them. But that buildup and that strain was enormous, because normally EMS can go anywhere in our community. We go where a lot of people don't want to go, where home health aides may not want to go, dangerous neighborhoods, because we're always there to help, and no one really messes with us. I mean, we're looked at respectfully in the community. When this happened, it was anybody that represented government, anybody that represented public safety, so we suddenly became a target. He talks about down there, ambulances being beat on with baseball bats and bricks thrown at them and stuff like that. We didn't see that up here, but we certainly saw it down there. And that's a different world for EMS, to go to being the trusted ones to being the not trusted ones. So in the beginning of the book, he talks about, and I think you remember this, Asian couple. And he goes to the call, and the wife is deceased while she's asystole. So they work her for 20 minutes, and they can't get a call pulse back. So he goes outside, because the husband went outside and was standing by the car. And here he is in a gown and a mask and gloves. And you look at people's expression, and you take this away, it's really hard to understand the expression of empathy in something like that. So normally he would touch somebody and talk to them quietly, but he can't. He's got to stand 6 or 8 feet away, because this guy's probably got COVID. He's got to talk through a mask, it's muffled. He has to repeat himself, so now he's almost shouting, "I'm sorry, we couldn't do anything for her. We've done all we can. She's gone." And the guy loses it and says, "No, this can't be." But he can't comfort them. And so from a paramedic standpoint, when you tell someone your loved one has passed away and you've called the code of the field, it really is important that they see how you really feel, because when you're in the moment, you're focused, you're right there, and that's your goal, your adrenaline's running. When you resuscitate someone, the dopamine hits in your brain and it feels good, but when it doesn't, it's kind of like, and you'll see EMS just kind of drop their shoulders and their chin, and it's over, we couldn't do anything today. But then you go out, and the comforting of a family member is kind of a closure for you as well, because you're now intimate with those people. You've shared an experience with them, and so he could not do that in the beginning. He talks a lot about diet. As he gets into this, I can't sleep, but I'm tired, but I got to go to work. So he goes from 1 Red Bull a day to 6 Red Bulls, because caffeine is going to be his fix. He talks about eating free food at work. He has a desire for sweets. He wants his sugar, and he lives alone. So he's, I think, depressed. And he can't sleep, and his mind is racing. So all of a sudden, he goes from 225 to 230 to 235 pounds, and he continues to gain weight. He talks about there's no more adrenaline rush. I think he said, it's just sadness and tired. And for those of us that have been in EMS or law enforcement, that's burnout. when you lose all that, then you're burned out, and it's time to get away from it all. There was an old woman who died, and the family had waited an hour to call EMS. They had taken a scarf and tied it under her chin so her mouth wouldn't gape open, and kind of respectfully put sheets over her. And that was their culture. So EMS responds. The son takes him aside and says, "She stopped breathing over an hour ago." He said, "Okay." So they checked. She's dead. There's nothing they're going to do, So the medic calls to get a time of death. And the physician on the other end of the phone says, no, start an IV, do CPR, give it a dose of epi and an amplified curve. And she's like, what? So he takes the phone from her and he talks to the physician. He says, hey doc, this is Lieutenant. She's been dead for an hour. You know the protocol. Do CPR, start epi, start bicut, take her to the hospital. Because the protocol had changed. It was 20 minutes, call for time of death. Now it's back to the normal. Do it all, take her to the hospital. So he says, doc, I need a time of death. He says, Lieutenant, you know the protocol. Doc, I need a time of death. Lieutenant, start CPR, give epi, give bicarbonate transport. Doc, I need a time of death. Finally, the doc gives up the time of death. Because he's like, 2 weeks ago, I resuscitated a 35-year-old guy. I was trying to resuscitate a 35-year-old guy. 20 minutes came, his time was up. He didn't have any past medical history or anything, and I had to stop. Now you're telling me I got to try to assault a dead woman in front of their family, cut the clothes off her, start CPR, put an IV in an intubator? He's now, they've been on the front line of this so long, and the only ones that now they're beginning to push back on protocols that don't make sense. And so that's his sort of pushback, and finally he gets a time of death. So in an effort to try to save some time for discussion, I have one more I want to read. And I think this is kind of the closure for me. It talks about a man that had died. I went into the living room, the paramedics would remove the IV and the breathing tube and put the man back into the bed and pull up the sheets. His wife was sitting on the edge of a couch that was covered in plastic. She leaned on the arm of the couch and looked out the window at the street. They were Russians. I wondered if she and her husband had come to this country together. I wondered how many decades they had been married, what kind of life they had built together. I approached her, she looked up, I removed my gloves. I bent down and I put my hand on her shoulder. We came a long way from the day in Shepherd's Bay when I had to stand several feet from the inconsolable man. The infection rates were now low enough that we could drop our guard a little. I'm afraid he's gone, I said. There's nothing more that we can do for him. The woman looked at my face, her eyes were blue like her smock. Her expression was soft. She didn't look surprised, like she was expecting him to die and accepting her husband's death. She put her hand on top of mine and slowly patted it, like a grandmother soothing a child. It's okay, she said in English. It's okay. A few minutes later, the police arrived. They would take custody of the body, the medics I gathered, and our equipment. I asked the woman if she wanted to be with her husband, and she nodded. She went into the room and sat next to him on the bed. As we left, she was stroking his hair. So to me, that's kind of a return to normal, right? So now you can show that empathy. Now you can let your guard down a little bit. Now you can be compassionate. Now you can help others through this very difficult loss. And I think that was important. One of the things I wanted to talk about just briefly was line of duty death. So line of duty death is when you're in an automobile crash or you get stabbed or something while you're on duty, right? COVID created a different and an interesting quagmire for people, especially in healthcare. What is a line of duty death? So for fire services, if it's within 24 hours of your last duty, it's a line of duty death, even if you're home and have a heart attack kind of thing. With COVID, let's say you treat, like Anthony did, 14 cardiac arrests in one day and they all die. And you go home, and 3 days later you get sick, and then you die of COVID. Is that a line of duty death? Employers are saying no. You died at home, well after your shift. But where did you get COVID, especially if you live alone? And so those things are still being sorted out. And when I looked to try to look up the number of deaths related to healthcare and to EMS, NHTSA reports one number, Kaiser Permanente reports a different number, federal government reports a separate number. None of them agree. And I think that's one of the things that as we go forward in the years, we'll begin to see the impact of COVID on the healthcare workforce, including EMS. EMS is unique. We fall under the Department of Health for regulations and licensing and certification and everything else, but we operate in the public safety world. You know, we're on the street, we get the 911 calls, but we don't report to public safety, we report to public health or the Department of Public Health at the state level. And we work closely with our colleagues. So I am in the public safety division, EMS as is fire and probation, etc. But I used to be in the public health department at West Fall Road, so we switched over. because it made more sense, because I spent much more time in the public safety side of the house than the public health office side of the house. But we really work collaborating together with our public health partners. And one of the things that's unique in Monroe County is the focus on collaboration. And you know, they say if it doesn't break you, it makes you stronger. That phrase doesn't apply to COVID and EMS. EMS didn't get broken, but it got bent, and it still is, and we're still suffering from it. From 2017 to 2022, we lost over 40% of our EMTs and paramedics in Monroe County. We were already in a difficult situation before COVID hit, but COVID accelerated it and put us over the edge. So right now, like I said, we're bad, but we're not broken, and we're trying to fix it. And both the county executive and the county legislature have approved ARPA funds, so we can do academy-style training classes for paramedics. So if I'm an EMT and I want to become a paramedic, I usually work full-time as an EMT and go to class at night, and that's very difficult if I'm a single parent. I've got childcare issues, especially during COVID when they're learning at home. So what we did was we're creating an academy that will open up this fall, where EMTs and paramedics will go to class Monday through Friday and be paid while they're in class, and we'll provide on-site daycare. That's important to us to be able to reach out to non-traditional people and get them involved in EMS, because you can see from the statistics, we represent the community we serve. And so we want to get some of those members who may have an interest in EMS the opportunity to do it without giving up something. So if they're doing something else, they can stop work and they'll get paid full-time to go to class, paramedic class, and EMTs. That helps to bolster our ranks, because when we met with the EMS leadership and the chiefs in the county, one of the things they said was, we need more people. That's the common denominator. Throwing money around is not going to fix it. That's going to be gone next year. But fixing the core problem is what we want to do. And our county's been very receptive at opening up and helping them do that. So I know I talked for 52 minutes. I've never been really good at time management. But I'll open it up for any comments or questions. I'd like to hear the thoughts from everyone here.
Thank you so much, Tim. Who's got our first question?
Thank you for your wonderful speech. My question is, how on earth are you not essential services?
So I guess I would say that we're new. We started in the 60s, really, 1960s EMS. So, you know, Ben Franklin started the fire departments back in the day. They've been around hundreds of years, law enforcement too. So why we're not in essential service, I think there are, I think there are 17 or 18 states that consider EMS essential services, and we don't in New York. We worked with our state senators and our assembly and our governor's office through lobbyists to get it put into the budget, and it was in the budget that EMS was an essential service. My understanding is as that budget dribbles out that it was taken out. We'll work with our assembly and senate colleagues to get a separate law identifying EMS as an essential service, because I think all of you would agree EMS is an essential service, and nothing proved that more than this pandemic when we were the only ones out there for this.
So where does funding come for police? Where does funding come from for fire? And then where does funding come from for EMS right now?
So you guys get your tax bills. So you see general funds, you see fire district taxes. Law enforcement gets theirs from a tax-based system. EMS gets 90% of their funding from billing insurance companies for transports of patients. So oftentimes if we go and see a patient, let's say a diabetic who's hypoglycemic, we start an IV, we give them glucose, we wake them up, and they sign a refusal not wanting to go to the hospital. We only get paid to transport. If we don't transport that patient, we have all that risk and liability associated with that call, but we don't get paid for not transporting that patient in most cases. Likewise, we only transport about 70% of our patients that we see. A lot of those patients are treat and release. There's a motor vehicle crash, somebody calls it into 911 that's driving by. We get there, there's no injuries, but we expended resources to get there and to do that. And so most of the money comes from insurance companies. And as you know, Medicaid has never paid their fair share. They're way underwater with the cost of the service provided. Medicare, very much the same. So private insurance has paid a decent amount. But trying to get equity in the insurance companies to pay, and it's true with hospitals, it's true in general with healthcare, that some of those insurance supplied by government don't cover the cost of the service. So in some instances, the towns and villages may help in their general fund. Pony Falls is actually an ambulance service for the village, so there is some taxpayer funds to offset what doesn't to offset the costs that are not met by the revenue created from the EMS transports. In some of the cases, that's the case. In others, it's not. It's, you know, you have your funding, do the best you can with it. Costs continue to rise. One of the things he talks about is the inequity in pay, right? So you go to the motor vehicle accident, and you got the cop, the firefighter, and the paramedic, and the paramedic's the most highly trained, and they're the ones going to fix you, and they're the lowest paid. How do we get that pay rate up to be equitable to what others make? And I think that's something that the EMS community is focused on, but they're limited on what they can pay without going out of business and losing money because of the insurance reimbursement problem. So we continue to work on that. And as an essential service, it would put it then on government to say, okay, what do you guys need from us to keep the service level at the level that we want? And I think that's the important part about trying to be an essential service. Why we're not an essential service is not from lack of effort from the EMS world.
As a follow-up to that, what, as we citizens, what can we do to help you?
So essential service has got to be at a state level. So, you know, you all have state senators and state assemblymen, and I think a letter or contacting their office and asking them that same question, what do we do to help EMS become an essential service, I think would be helpful.
Is there any way that you can send like just a sample letter for us? Maybe.
I can have, so there's an association of EMS chiefs that has that, and I can have them send it to you and you can forward it on.
Yeah, we could just pick them up here at the library and send them up. Yeah, that'd be great.
Yep.
More questions? I know I didn't say this when I was doing your bio, but you have 3 grown children.
Yep.
And you mentioned one is a nurse.
Yep.
And then you had talked about historically people coming up through the ranks. Are any of the other children EMS people? Or?
So my daughter, when she was in college, she became an EMT. It was kind of unique because I'm in my office and I'm listening to this scanner, and she was volunteering for Gates Ambulance. And they had run out of ambulance, so they were mutually a call to a nearby town. She was at Strong and just come into service, and you hear her on the radio saying, "This is 6179 in service, we can take that call." So the one nurse, she was a school teacher who didn't like the regulations on teaching school. She wanted a little bit more freedom in the curriculum. She had gone to Mercy, and they had that there. So then she went back to St. John Fisher for a 21 Bachelor in Nursing program that was really accelerated. And so, yeah, she became a nurse. And it's interesting because when we're talking about it, she was working in the hospital and she would see a patient that had COVID signs and symptoms. And she would go to whoever was controlling the N95s because they had them under lock and key. And she said, "I need an N95 to see that patient." The policy is you can only have an N95 after the patient tests positive for COVID. So it takes 3 days to get the test results back, right?
Yeah.
So she said, then, you know, she would get a letter from infectious control saying you were exposed to a COVID patient. You know, so it was a shifting sand in the hospitals too because of the limited PPE. So I do a lot of woodworking. So I have N95s that are not medical N95s, but they're dust N95s, but they're better than nothing. So I said, take some of these. It's better than nothing. So they told her you can't have those. We have a policy against bringing in your own. Bringing in my own, something I'm going to wear. Just I got my own shoes on. You know? So they finally kind of went and eased that a little bit. But the nursing, I mean, they faced a very, very, very difficult time, much like we did in EMS. The difference was they could take turns. They could say, we're going to limit you to 5 or 6 or 8 minutes and get you out of there and then get somebody else and rotate you in. But in EMS, you couldn't do that. When he talks about going into a call where they're doing cardiac arrest on somebody, and he looks individually at the 4 faces, and they're all diaphoretic and sweating and pale. So he's in a 10 by 10 foot room with 5 people who probably all have COVID, and he realizes the concentration of COVID virus in this room is through the roof. And then you get in the back of an ambulance with patients, and you're in an enclosed box for a period of time. So you don't have that option to do 5 minutes or 10-minute visits and switch out. And so that's really, when it came time to vaccinate people, I fought hard that the frontline EMTs and paramedics be vaccinated first because they were the front line. And initially the governor wallowed on that and then finally agreed that they were the frontline runners. So we actually, over in our fleet building, we actually set up a vaccination clinic. And paramedics and EMTs, we were one of 2 counties, Erie County and Monroe County, teamed up together to have paramedics do vaccines. Now, paramedics are sticking needles in people's arms every day. But vaccines are a different story, whole different regulations. So we could have nurses come in the pod, point of dispensing, and give it, and they've never been clinically active. And then we get paramedics who are doing it all the time, we're not allowed to. So it didn't make a whole lot of sense to us. Finally, the Bureau of EMS and Trauma agreed with us and gave us, almost overnight permission. We had a conference call. I got a call like at 7:05 on a Friday evening. Can you be on a call at 7:15? I said, yeah, I'll be there if it's about this. And I was, and we convinced them that we had already done it for H1N1. We had the training modules, we had the knowledge, we had the skill sets, and our medical director was approving it, so let us do it. And they finally agreed to let us do it. And so it was kind of unique. The paramedics loved it because they were giving vaccines to their colleagues in law enforcement, and their colleagues in 911, and their colleagues in the fire department, and their colleagues in EMS. So they worked their normal shifts, but then they worked extra to come. We hired them in the county, worked extra to come to the county to do this vaccine. And it was Moderna. And one of the things with the vaccines is when you open up a vial, you have 10 doses. And you have to open it up because it has to be kept so cold. You have to open it and put it on the counter like an hour before. And so you don't want to miss any of those doses. So we had a list of people that were supposed to come in for the vaccines, and some of them would come in. And we would call them, and there would be 315 or 716 area codes. Oh, I got my vaccine yesterday at another place. People were signing up all over the state to make sure they got a slot. And then they weren't calling us until that slot's open so we could put someone else in it.
Yeah.
So we had a group of people who had signed up as kind of extras. So when we find, I got 9 doses and I got no bodies to put them in, we'd call them in at 11 o'clock at night, because we closed at midnight, to get those doses. So they came in their pajamas and gowns and stuff like that. But they wanted those doses, so we got them those doses, and we managed that pod. So I'd work in the Emergency Operations Center until 4 or 4:30. I'd grab a bite to eat, and then I'd go over and I'd be the pod manager until midnight, and then shut it down, pick up the next day, and do the same thing. But it was very, very successful, and that was purely in partnership with our public health colleagues. It was great. They created the online form where you can sign up electronically. We had every 15 minutes a new group of people come